participated as an opponent. In those settings, the opponent usually stands up. And so it's my first time to be an opponent at Makerere, but I've examined here. So that's why I am standing up. Two, you can see this big book. And Dr. Mwaka has told his story. He selectively chose some things and presented to you. My role is not to oppose him. My role is to take him back to that big book and purposely select some aspect and ask him to talk about it. So he has to tell the story as seen by another reader now. Like if you had the opportunity to read this book, this may be some of the things you'd probably ask him. But you'll only find the book, you'll not find him. So that's my role this morning. It's not to oppose him, it's actually helping to shine with the work that he has done. Third, I wish to congratulate Amos for this very important work, but on a personal note, with my colleagues in the profession, to welcome the physician to join the male gynecologist, probing into this very intimate area and quite sensitive. So that's good progress from the physicians. So I was read your work, and this again is excellent work and really congratulations. We did work in Gulu, and looked at the community, looked at the number of people, not only the elders, but he also interacted with women in the communities who were not necessarily sick. Many in the communities were not necessarily sick. He also interacted with actual women who are afflicted with cervical cancer. I think that's true. And he also had the opportunity to interact with the health workers. And so it was work which really went across the communities, coming into the health facilities and so on. So I would like to start to give you opportunity to explain a few more things by going to this page of your thesis. That's why I would like to start and put it there so that people can see what we are talking about, because we don't have the big book. So on this particular page, you have operational definitions, and the operational definitions go from layperson, date of first symptom. The layperson, according to him, is any person who resided and worked in the study community and did not play any special roles as healers of any sort in that community. So once you give somebody a herb, you are no longer a layperson. You are now a health worker. You know, there's traditional salt. So if they give someone sick, a grandmother gave the woman salt, that traditional salt, ash, to take. That will also become a healer now. And so on. So quite interesting list. So I wanted to add a few things on that list, and I just wanted the Amos to maybe explain to us. There are keywords he uses in this work. One of them is awareness. What is actual awareness?
Thank you, Professor. Awareness, in regard to what I'm talking about, is having knowledge of something, being able to perceive of something. And this perception is in itself known to the person who is perceiving.
Okay, that's according to Mwaka.
This is one question.
Okay. So it's good to sharpen the bit. The next one is perceptions. What are perceptions?
Perceptions have got to do with our senses, what our senses tell us. And in this case, I'm referring to the senses about what would constitute a sickness, how one would think and reflect what they think in terms of a message. Now, in that message, what they feel, in this case, is the perception.
Okay. So you can, and then what's the difference between perceptions and beliefs? You know, these are common terms when you read through the thesis. And I expected to find them in this section, so that I'm not using Oxford Dictionary. But the difference between, maybe you define beliefs, then you go back to the difference between perceptions and beliefs.
Right. Thank you. So beliefs have got to do with facts, artifacts, and norms that a given society holds about a particular phenomenon. Now, those constitute their beliefs. Now, the difference between perception and beliefs, it's a thin line, but it's quite very important. Beliefs have been in the community for a while, is perceived by many other members of the communities, and is a lot uniform in the given community. Perceptions are a lot more temporary themselves, change a lot more with time, and may vary a lot more within that, even within the community.
Okay, so you can see when it defines awareness, it touches on knowledge. And so that's important to remember. And then perceptions and beliefs is a thin line, and I hope you remember that. In the process, he brought another big term. He said the phenomenon. Now, what is it? Amos, what's now the phenomenon?
Thank you, Professor. A phenomenon, I will put it in this case as an occurrence.
And, yeah, it's correct. The phenomenon is a fact, it's an occurrence, it's an event. And so what would be the study of phenomena, what is it called? Up now, phenomenon is an occurrence, an event. And what is phenomenology?
Thank you very much. Now, phenomenology in itself really is a school of...
You see, Amos has a lot of qualitative studies. That's why I'm spending a bit of time on this part of definition, because later it becomes rich and very interesting. Yes, go ahead. Yeah.
Phenomenology is a school of thought, is an approach to study occurrences of diseases, occurrences of events, occurrences of different aspects, which are followed through by the person who is studying, by perhaps being unique and then describing it a little bit with more detail than like the method that I use in my analysis.
Oh, so that definition is it from anthropology, social science, or which dictionary?
Professor, I will desist from making accurate definitions from dictionaries. I will perhaps keep giving an operational definition as I understand it and as I use them.
Okay, so perhaps in this part of your book, it would be important to bring in this issue of awareness, because you use them so often. And knowledge, beliefs, perceptions. You brought in phenomenon, and then took me to what is phenomenology, which is actually a study of structures of consciousness. Because these terms, perception and awareness, is beliefs. So a study of structures of awareness, consciousness and awareness. Again, you have to define and differentiate. So when you study the structures of consciousness experienced by a person who has been touched by this event, the phenomenon, that is what phenomenology is. You study the structure of consciousness experienced by the person touched by that event, isn't it? And he did study women, isn't it, who had cervical cancer. So they experienced that phenomenon, isn't it? So in short, he did the phenomenological studies. Because a lot of studies deal with the 18 women, the 300 and something women who had experienced these events and so on. And we'll return to this later as we go down. The other thing which we could move on to is in your introduction, in the background to the study. And in the problem statement which I have put there, 1.2, I'm giving you the opportunity to see something different from what you put in the PowerPoint, you see? And so in the problem statement, you refer to limited data on community awareness of cervical cancer. And I was looking through what you have put there in terms of limited data. and under Uganda, is there other data other than the one you have put here, which is actually there in relation to awareness? I'm just looking at what you have put there. Did you have to try very hard? I know it's limited, but
yes, thank you, Professor. I had to make some reasonable efforts to be able to find local data on awareness of cervical cancer, particularly
or perceptions, or beliefs, or knowledge, or the phenomenon. Okay. You see, that's why I have to start from there first. You see? Okay, go ahead.
Yes. So yes,
somebody has. Yeah, go on.
Right. Thanks, Professor. So there is indeed limited data that one can get, particularly published data on the different communities or societies in Uganda on risk factors, symptoms, as well as the way treatment is done for cervical cancer from the community perspective.
Yes, there was a formative study done by WHO and PATH 2010-2011 when we were just introducing the HPV vaccine in the country. I don't know if you have come up with that formative research.
I have I came across the HPV what I call it, by PATH, and that came actually about the time when I was starting my studies. I started my studies in 2011. So prior to that, indeed, as you did a formative study in 2010, there was really limited data. And I perceived that, and in 2011 I started the journey.
Okay, but today is 2015. We are writing the thesis today. So you have to keep rethinking a few things the way you present. You have to keep rethinking how you present. Let's move on. The general aim, you can see there, and then the specific objectives. Why these 5 objectives?
Thank you, Professor. Why 5 objectives? Now, I needed to try and comprehend the process of health seeking. And I decided to do this by looking at the community, where health is made and where disease perhaps starts. And so understand their perception and beliefs about this disease. And then I decided to come in and look at those who have developed the disease, the patients with cervical cancer, but also the health workers who deal with them. In my understanding, if I triangulated findings from all these categories of people, I would be able to have a greater whole, which perhaps might be better than the sum of the parts. But the parts then relate to those 5.
Before we get to the part, you have said in a problem statement that there is limited data. Limited data. So you're looking at the objectives. Are you trying to fill?
Indeed.
So
I need to fill that gap of limitation in data, which undermines the ability to improve on health services.
Okay. You also refer later in the book, in the work, you refer to research questions, that you're answering research questions. I know one is also trying to get answers to these specific objectives, but I looked through this big book and this, I didn't see the research questions. So what were the research questions?
Thank you.
Yeah.
I chose a format provided for by the university, which you can actually do without necessarily relisting research questions. But if I were to ask, they would more or less be the question form of the objective.
Okay, so that was a little bit difficult, when you're outside and you're reading work. And then in the process, he emphasized rightly that the work is going to answer these research questions. And then I was perusing through the document and I was trying to say, we're trying to fill the gaps. I didn't find the problem statement, and then, it took me a while. I got a little bit of a headache, but the questions are there. Very implicit, but they need to come out, and they need to be presented fairly well. And so from the objectives, we'll move on to other aspects. I thought that was a good section except for that little problem. And you need to tailor the objectives to really be close to the problem you've identified, so it's not going in another direction. Chapter 2 of this book is on the literature review. Again, we did very extensive literature review, quite good, and with different titles. I'll just point out a general trend, and here you see, for example, 2.4 is reviewing cervical cancer mortality in Uganda, and of course data which has been collected, one of which is Chadon registry, and I was just trying to figure out why you didn't try to tease out mortality related to the north. 2.4 looks at cervical cancer prevention. And again, in cervical cancer prevention, there will be a lot of literature there, as I have shown. I was a little bit disappointed that at the end of that extensive literature review, the literature ends up with studies in Ethiopia, in Asia, Latin America, and none in Uganda. Why?
Sorry, Professor, is this in the particular section or the whole section?
I'm sure you know. 2.4, 2.3, 2.6. That's what I wanted to show you. You can open the page. It's 2.4.
So,
that's why I wanted you to be there with an open book.
Right.
Yes. It meanders here and there, Vietnam, comes around Latin America, then I didn't see Uganda. And we have some data on a number of areas that he reviewed in relation to the study. Earlier on, even when you just look at the chart on the registry, and the data that we report, then data from Uganda Cancer Institute, again there is some inkling, you can get some information about northern Uganda. So that's why I was feeling a little bit uneasy there. That the literature review, I read, it was beautiful, really nice. But then where was Uganda? Then northern Uganda.
Thank you. I know we will have very good data on the incidence and mortality of cancers from northern Uganda when the new registry takes place. The registry is about 6 months old, and indeed that is the only best way that data on cancer can really be made available in a reliable way. I definitely could have searched a little bit more in the grey literature by having personal consultations and a few unpublished work. I am sorry I didn't do much of that. I concentrated a lot more on what is available in publications and what would be authentic in terms of the registry data's coming. I am certain that will help us understand the incidence and the mortality in the region.
Okay, that's on incidence, but I'm just looking at specific areas, like here I've mentioned already, cervical cancer prevention. This formative study which was done by WHO started actually in 2006, and by 2010 there was already some information available, and the cancer registry. So it was well reviewed, except to finish the last slide, mining. I think that that's an area perhaps we need again to look at and see that we bring Uganda on board. Yes, even 2.5 in your book, if I may put it up for the benefit of the other students of your book, that's 2.8, that's on symptom appraisal. 2.5 looks at the importance of early detection and the importance of early detection of pre-invasive and symptomatic invasive cervical cancer. Again, the whole review there does not come down to Uganda. Are you aware there is a strategic plan for cervical cancer?
I am aware of a draft which had an opportunity of looking at, but I haven't seen the final copy of that plan.
Okay. So the formative study and that strategic plan definitely inform the literature review. I think that is very important. There are other work done by other scholars and so on, but I think it's important that area should be enriched. Let's go to chapter 3, and I will scroll down for the benefit of. So this is the fastest I can go. It says page down, and you can see how slow it is. Very interesting. So this theoretical framework. What's theoretical framework?
Again, I am going to describe the theoretical framework as a concept of how the work is going to be done, but based on already proven theories, already proven facts, or proven patterns. That's how I would personally define it.
And what's the difference between the theoretical framework and the conceptual framework?
A conceptual framework would simply be what I think things might look like when I get out there in the community, collect data. These are the things that these are the factors that might influence factor B, and factor B might be influenced by factor C, and eventually they might all influence D to get E. That might be my own thinking, and there may not necessarily have been already established theoretical background to that. There may not yet be have demonstrated a pattern exactly in that. But in the aspect of the theoretical framework, I am adapting a pattern that is already published or a pattern that is already known.
Okay, so I put the table which you presented again in the PowerPoint presentation. This figure one is called Model of Pathways to Treatment. I'm sure you've looked at this many times. So this is a model of pathways. Is this for the all the 5 studies?
No, Professor. This is basically for the patient-related study. That is study 3 and study 4.
Okay.
Yes, study 5 on barriers with the healthcare professional really I didn't use this model.
And this
study 1, I also did not use this model. The model that I borrowed in making my guide in study 1 is the Clayman's illness explanatory model, which is a model which explains how people conceptualize, try to understand diseases and how diseases progress and how diseases may be treated and or treatment may succeed in reversing the course of the disease. And
study 1 is that one with the 24 focus
group discussions in 2 different villages.
So how people would conceptualize disease at community level? Yes. Would you get that from the focus group discussion?
Yes.
Sure.
Oh, yes.
Very interesting. Yes. We'll come back to methodology later. I think in-depth interviews probably yes. Understanding. Focus group discussions, I'm not quite sure, but let's come back to this. So this model, it's not very clear when we present the theoretical framework, which areas it applies to. It's good to clarify that. This model, again, when you look at it, you see the orange above, but don't interpret it in terms of parties and politics. So, but you see the orange above. I didn't see a link as far as events is concerned from one box to another box. And I wasn't quite sure how to read it, but it was there. Similar the next one, which is perception. Is it perception? Processes. I just saw those round circles with arrows going, but I didn't see how they were related to each other. Usually my understanding is that if they're related to each other, they overlap a little bit. The circles would overlap a little bit, isn't it? So I found a bit of difficulty trying to understand, so how does this one relate to the next? So those circles there for processes are by themselves. They don't relate upward vertically or horizontally. And similar the next line. And then I understood when I reached the green for DP in inverted commas that those would be like the cross-cutting issues. Is my interpretation correct?
I would not say yes or no, Professor. Now, this is a model that I adapted from studies that I've done. And as I said earlier, the earlier model to this was called the Anderson model, which referred to the L-seeking processes as delays. And people seem to think that it is not the case that people will always delay, but rather there is an iterative process that goes on. When I begin to feel some itching on my leg, by evening I am going to try and give some explanation to it. And perhaps I think that is what the authors of this model call the detection of bodily changes. Now, that goes on within myself. I will try and appraise it, and that is in the first interval. In my process of appraisal, I don't get only one answer. I might think maybe because I stood for a little bit too long, perhaps I didn't sit quite well as I was answering some of the questions, and so I compressed the nerve. So there are a number of things that go on in this process, and that is why you see the circle is going around and around, and it attaches onto the second one. Oh, sorry, it has disappeared.
It needs a password. This one was not just about it, imagine the computer goes on. Yeah, now we can see, They just touch. They just touch. Very good. They just
so this to me really is a very important model, which a number of researchers, particularly in the cancer field, are really using to try and understand the processes that go on within the persons. And these processes are really affected by these factors. And if we do not understand these factors quite very well, then we end up actually delaying going into the next interval. And when we delay getting into the next interval, definitely the diagnosis is not going to come out. And so I will give them a kind of explanation. And that is the event that is occurring. So an event occurs, I detect the abnormal bodily symptoms, and then I begin to try and say, what could this have been? And I try to give some explanation. I go around and around, but eventually I have to make up my mind. And if I make up my mind, I perceive that actually it's not just sitting on the nerve, but I have developed a problem. So this is the second event now occurring, and this event is leading me into my next interval, which is now the help-seeking interval. I now decide, where do I go? Which physician do I go to? Or do I go to a gynecologist? Who really can help me much better?
Okay. So of course, Amos aspires to be a doctor of philosophy. You have to be a doctor of philosophy. Okay, good. So one of the things that you have to do is, there's a model, it's being used by many other people. You should be able to predict the model. You should be able to say, also this model exists and does this, but I found the following difficulties or handcuffs with it. So it puts him, you own it in your thesis. This is your book. Yes. You acknowledge this model comes from this and that, so that you can see the connectedness between from the contributing factors going vertically. So to say, that would be part of your comment on the model, then so to say, put it there.
Yes.
Of course, in the narrative, later down here, you talk about events, and you mention them, but doesn't answer the question, but how do these relate to each other, and so on. And that's what I'm showing there, 3.31 events, detection of bodily changes, but what was explained when he gave you your back to look at, you should be looking the other way, and so on. And so, yes, those were very interesting. Very interesting model there. We go to chapter 4. Chapter 4 on methods. Again, I did enjoy looking through and reading through this. And the methods, I'm going to close this a little bit. And I want to your computer does not have Adobe Reader? because I want to view this item. Amos, I want you to turn around now and look. So what is that?
So this is called Mwaka dance.
Yes.
It's one of the cultural dances among the Choli people. And usually it's related with preparing for war. Preparing for warfare. That is of importance.
Okay, I will show you another picture. That one there. What is that one?
Professor, this is what the famous writer, Professor Mwaka, calls the stack dance. This is a Goshic dance among the children, the stack dance.
So, how are they related to your research?
Well, these two, particularly the second, particularly the Ragana dance, this is a dance which is culturally practiced in the process of getting a partner for marriage. So when we are talking about cervical cancer, we are looking at HPV infection as one of the most important things. Indeed, I would imagine that without HPV infection, there would be no cervical cancer. Since I'm not a gynecologist, I will not say there will not completely be. Medicine never happens. But I would say that without HPV infection, the incidence of cervical cancer and the burden of cervical cancer would perhaps be negative. Now, these are the dances where people go and start the process of courtship and perhaps intercourse photos. And the earlier a woman begins getting exposed, we know early onset of sexual intercourse, multiparity and all these are risk factors for cervical cancer. So really, I think this is how I would relate this directly to what the work that I've done.
Okay, so when I was reading through, I go back now to your thesis. Yes, study area and completion, the background. I kind of missed it because you have a lot of qualitative studies, social science studies. I missed this social bit coming out. And I was seeing a lot of a doctor, epidemiology, and the like in the context. That's why I deliberately put these pictures here. Yes. Two, because you need to think like a social scientist then, or an anthropologist when you're writing research. To tell the story. You are not to tell the story, isn't it? Yeah, to tell the story. So this needs to come up. The other thing, looking at the references you put here when you describe Voodoo and the Acholi. For example, there is this, I can't pronounce, but it's Atkinson, published the book 2010.
Oh, right.
Yeah, I was wondering, that sounds recent as a foreign name, and there are Ugandan authors about the Acholi. You just talked about the tech. Then there are also legal documents about Gulu and the Acholi. That's actually put those pictures there. I said there's some other sort of approach that's immediately recognizable about introducing in your book here this particular area. I also noted in this part of the chapter when you refer to Macho and Gulu regional referral hospitals. You talk about operational healthcare professionals. I didn't understand what this one is. Operational healthcare professionals.
So in the context of this study, these are healthcare professionals who are retired working with these two hospitals and who on their day
So
to
you
day.
see that difference about the Atkinson
Yes,
yeah.
Now, Professor G,
No, let's go back to the other one, yes? Yes? Go ahead.
which one? The operational definition
Yes.
of operational. So my operational definition of operational health workers, this aspect are well-qualified health workers working in the Department of Obstetrics and Gynecology who, on their day-to-day routine activities, interact with patients. Those are the ones that are referred to as operational health care professionals.
It is under the first chapter we looked at operational definition. It is a standard definition?
I need to think about that.
Okay. So when you introduce a new concept like that, you go back and put it there. So at the end of that paragraph, which I've flashed there again, it's referring to Gulu Regional Hospital, 250 beds, and at the center of the municipality, and then the reference to Uganda Bureau of Statistics. And I was wondering, if you want to know about Gulu Regional Hospitals, why would you go to Uganda Bureau of Statistics? Is that how you want to see operational health workers definition? I became suspicious, you know.
Sorry, I didn't get what.
If you are describing Gulu Regional Referral Hospital, which is the credible source of information about Gulu Regional Referral Hospital?
The Ministry of Health.
Yeah, that's the Ministry of Health. So when I saw the operational health workers, I suspected it was Uganda Bureau of Statistics. You see the reference there for Gulu Regional Referral Hospital. I would have expected that when you are referring to Nacho and to Gulu Regional Referral Hospital, the credible source of information would be Ministry of Health, first and foremost, not Uganda Bureau of Statistics telling about the number of beds in Gulu and the health workers who are there, and so on. So I was just trying to clarify, help me understand how some of this terminology came on board, and so on. The rest of the methods and rationale as presented, and I would like to save time to put another document, bring together methodology and the objectives, rather than going one by one. And I prepared this document. Since I don't want him to be turning around to look there, I said I printed it so that he can look at you. Yes, like that. So that you'll be looking there, he'll be looking at you and answer the questions. So we see here the first study there is on community perceptions and beliefs about cervical cancer, isn't it?
Yes.
I'm borrowing this from your table 1.
Yes.
Which is at the end, towards the end of that chapter. And so that's the title of this particular study. And the data collection method is focus group discussions and key informant interviews. 24 focus groups, and 175 men and women, and that's the duration, that's the period. And of course, one of the key things here is community perceptions and beliefs. That's why I wanted you the other definition of knowledge, because knowledge comes in later, but not in the title. So these focus group discussions, what did you hope you get by conducting focus group discussions, as opposed to another method of collecting information about community perceptions and beliefs? You are studying community perceptions and beliefs. The objective is there. You see the objective right below it? Yeah. The objective says what? It's there. I've printed it. Printed it there.
To explore the perceptions
Yes.
and beliefs about cervical cancer risk factors, symptoms, cause, treatment,
So somebody will help us. That's a social break, not a health break, but a social break. Okay, I'm going to start with the social break. So I have highlighted in community perceptions, beliefs, and cervical cancer. And the objective is to explore perceptions, and I have highlighted one word, challenges, in the objectives.
Yes.
And when you go to the papers which are published, which is study 1 and paper 1 and paper 2, you are studying now knowledge and barriers. And I was trying to understand, do you use these terms interchangeably?
Knowledge and barrier?
Because the methodology is focus group discussion, yes. Get this information about community perception. You end up with these words of knowledge and barriers are not in the objective, but they turn up now as you publish the data.
Oh, thank you. Now, the word challenges and barriers are used alternately.
Alternately or interchangeably?
Refer to a similar thing. Interchangeably, yes.
So, according to which definition?
Again, as I said earlier, it's about what I am able to perceive from the data that I reflect and then pick a word that describes it appropriately.
Okay, so it might be wise to stick to standard definitions, because people who are reading, like me reading out there, we get confused when challenges turn out to be barriers. And knowledge is the same as perception and beliefs, because that's what the study is about. It's about community perceptions and beliefs.
Yes,
but somehow we publish about knowledge and separate it from perceptions. If you look at paper 1, an exploration of lay perception, beliefs, and knowledge. They have now come off from perceptions and beliefs, but not in the objective.
Yes, here, Professor, I would say on study 1, paper 1, the word knowledge is appearing here as a result of a little bit more scrutiny of what awareness is.
So what did you do in the focus group discussions to be able to tease out knowledge also? That's what I was looking for. What did you do in the focus group discussions and the key informant interviews so that you end up being able to describe knowledge also?
I think I have not understood the question.
Focus group discussions, that's the methodology, isn't it?
Yes.
Yeah. And the objective is there quite clear. So I'm just wondering how you end up with findings on knowledge.
So focus group discussion, in my understanding, Professor, is a tool, is a method, is an approach that I am using to be able to get information. Now, I immerse myself in this information, in this data, and I derive understanding from this data. And it is the understanding that I have derived from the data, having used focus group discussion to collect the data, that now I am reflecting. And I'm reflecting it here now as knowledge of the people about the phenomenon that I'm describing.
Exactly, the phenomenon, you see, and the phenomenon structures of consciousness.
There are two things, Professor, that I would like to try and put clear in my mind. I would like to put clear in my mind the difference between a phenomenon and phenomenology as a method of study, or as an approach.
Good.
So I am referring here to a phenomenon, an occurrence, a fact of something, other than a method of study.
Okay, so then knowledge would be a fact?
Well, knowledge in itself are a collection of perceptions that translate themselves into a reality.
But the knowledge leads to perception, which one?
The other direction.
The other direction. Okay. So that's the methodology on that particular study and the difficulties of marrying the methodology with the outcome subsequently, right across up to the end, which is a publication. I think clarity is important. The second study is awareness about cervical cancer risk factors and symptoms, isn't it?
Yes.
And the objective is there. I've put it there so that the others can see. And the study was a cross-sectional population-based survey. And you published the paper 3, isn't it?
Yes, it's published now, yes.
Yeah. And 448 men and women. And we're trying to figure out how you arrived at this sample size. What were the assumptions?
Thank you, Professor. So in the first place, Gulu district at the time that I was going to do the study had 3 constituencies. Now, one is the municipality, then the other 2 is Achua and Moro, which I consider them to be rural and the municipality urban. So as I set out, I personally selected the municipality to include in the study. And then I randomly, by simple random method, selected of the 2 remaining, which I selected Achua. Now, one of the things that I would have done very successfully at that stage, if I had a list of households, I would have directly moved from having selected the municipality and Achua to the households, and then I get my statistics.
That's a sampling procedure.
That would be my sample.
Just about the sample size. How did you arrive at 414?
Oh, sample size in itself. So the sample size that I calculated was 384, assuming that what I am looking for, the ability to recognize risk factors, the ability to recognize symptoms was equal to 50%. Then I used the survey formula by Leslie, which gave me 384. But then I decided to oversample for the reason that I did multi-stage sampling approach, and I keep on losing, if I would say, power as a result of that design effect. So I kind of oversampled.
Okay, so the assumption was 50%. 50% was taken because
I didn't have data on awareness.
Awareness.
Prevalence of awareness of this factor. I couldn't find it.
Okay.
Yes.
That's why I was alluding to other studies which were carried out in the informative study by WHO. But your first study, you argue out that focus group discussions and quantitative methods sometimes are good to precede a quantitative study, isn't it?
Yes.
So after the first study which was done earlier, the time frame is there, May, June 2012. We are not analyzing to inform study 2 so that you could estimate the sample size better. That's the first question. Number 2, awareness of risk factors. Which risk factors? You can't, was it a composite scale or score? Or did you take a particular risk factor into mind? Or symptoms, treatment outcome? Because the objective mentions many things.
Right, thank you, Professor. Number 1, yes, the data for the first was collected May, June 2012, and then the second started in September. Indeed, I had an addendum to my questionnaire. I started doing the analysis of the focus group discussion right as I was doing it. And that's really one of the best ways of doing a good quantitative study. To inform even other focus group discussions were informed by the earlier ones. And so by the time I was starting the study 2, I really had information, the concept, the table that I showed of perceived causes of cervical cancer. All those were locally got from my study 1, the focus group discussion.
So why wasn't that information used to help you estimate the sample size for study?
Oh, sorry, it wouldn't actually help me because this was descriptive. It was just trying to give me the understanding of the people who never give me percentages. I couldn't calculate percentages from the focus group discussions and the key informant interviews. And I needed percentages to help me to calculate the sample size in that second study. So the other one couldn't help me, but it enriched my questionnaire.
Okay, but later when you're interpreting that data in the discussion, you talk about most focus group, most this, you give a quantitative interpretation. That's why I got caught up, saying now, in your interpretation.
So the reporting of qualitative studies has varied. There are a few publications about how they should be reported. Now, when I use content analysis, as I did in the analysis of my focus group discussion data, I have got two options. I can be able to report the proportion of the focus group, which is my unit of analysis, that shared a particular consensus. But I can as well simply refer to the issues that emerge without necessarily giving proportion of the focus group themselves. So even my notes there were not referring to the knowledge in itself, but rather the unit of analysis, which was the focus group.
Then if you're not referring to knowledge, then you contradict your first assertion of studying knowledge in that first study, which is published.
No, in the first study, I wouldn't say so, because my outcome from the focus group discussions are consensus. But I will not refer to the consensus from the focus group discussion as an item of knowledge in itself, because it wouldn't really be able to be so, because this is a group of people that come up with some consensus.
Okay, so I agree with you totally. So it's important then that in your book, you need to have a chapter on results. So that although that paper is published knowledge, which may be difficult to defend, in your thesis, your chapter of results, you're able to present a different picture, which is a true way of using data from the focus group discussion, key information interviews. That is very helpful. Because in your book, there is no chapter on results. If you had that chapter, you will now be able to correct that anomaly which exists, because the paper is already there, published, but when you actually look at how the data was generated, you do the qualitative pass, which would inform you in some way, then you move to the second study, and then now we're on the third study. It says, third study, if you go there, to explore 3 symptoms, appraisal, attribution, and help seeking. Is that correct?
Yes, Professor, you left me a little bit behind.
We're coming to that. Okay. Let's look at that study. We're looking at methodology now and implications of the methodology used for the results and how you interpret. So the next study is in-depth interviews. 18 asymptomatic or symptomatic cervical cancer patients. Is that correct?
Yes, symptomatic.
And the objective is there?
Yes, sir.
Okay. And I have highlighted in red things that were difficult to tie together. And you can tell us the story, tell us the explanation. Under study 3, paper 4, symptomatic presentation of cervical cancer in Uganda. And right at the end, it says diagnosis in low-income country. All along you've been talking about northern Uganda and Kuru. Suddenly for this study, you have run a more broader theme of low-income countries. And I was it David that was pushing you? What happened? But on extreme right, you realize you collected data in 2012. And then you collected data in 2013. There were only 18 symptomatic cervical cancer patients. Why did you collect all of them over the same period of time? Why did you have to wait several months later? There are no more patients? Or?
No.
There were no more patients?
There were patients.
Yeah.
There were patients.
So why the break?
I was convinced after searching literature that there was limitation in data in this area. Now, I needed to understand, and it is really quite an important aspect in qualitative analysis, to try and understand what you have. And so what I did, I collected data from 6 patients. And these were really massive amount of data. I gave myself time to understand this in detail, to try and so that it can inform the subsequent further data collection. And that is why, so there was a gap in between when I engaged further in transcribing. In this case, I did the transcription and the translation myself of the patient's information to gain that accuracy. So I needed a little bit of time to do that. And then I continued with further data collection.
Okay, usually the way they do when you carry out this in-depth interviews is qualitative research. After the first interview and transcription, you analyze that one first. Because you are using theoretical frameworks, isn't it?
Yes.
Yes. When you finish that one interview, then you go for the next one. You collected 6 and then analyze the 6. That's a different method. Usually you do one interview, you analyze it, then you purposely select the next one to fill the next gap, and send the third one, so that the actual number of people you recruit may end up being 7 or 9, because you have reached saturation.
Professor, the literature in qualitative data analysis is a little bit complicated. I would want not to discuss the detail.
So which model? No, but you need to mention here which model, which approach do you use. It has to be very clear which approach. Because the anthropological methods, they don't agree with each other, social studies methods, sociology, and so on, they do not agree, but you need to be very clear which method you have chosen and why. Okay? Otherwise, it's so difficult to understand why you first did it in 2012, then recruited others in 2013, and put them together. And you are studying a phenomenon, isn't it? And it's a phenomenological study. Phenomenology, isn't it? Hey. Yes. He's studying the structure of the consciousness, what the patients have experienced. They're experiencing cervical cancer, isn't it? You are studying what they experience cervical cancer disease, whether they will go for diagnosis, how they deal with the symptoms. Isn't that what you are studying? The pathway to diagnosis. One of the papers talks about pathways to diagnosis.
That is true, Professor.
Okay, let's move on to the next study. 4. And 4, I flash it again. Stage of diagnosis and associated factors, isn't it?
Yes.
Study 3 was trying to understand the pathway. And the pathway is these 18 women experienced cervical cancer symptoms and moved on to come or not to come, to seek or not to seek, isn't it? That is called okay. Let's move to stage for diagnosis and associated factors. The objective is there. I have highlighted in red, as far as the methodology is concerned, what a cross-sectional survey is. What is a cross-sectional survey?
This is a snapshot. I collected data from each of the participants at a point in time and did not make any further follow-up with that particular participant.
Okay. So there were 149. So how did you arrive at the sample size?
I consecutively recruited all the patients who came in a period of time. So I had, right at the time of...
no, that's a procedure. But the actual sample, you can't estimate the sample size in a scientific manner.
I did.
Yes, so how did you arrive at 149?
I used the Kampala Cancer Registry prevalence to calculate the sample size, which came to about 360.
Which method?
I don't quite remember what.
Calculate the sample size.
What?
Which method? Which formula?
Again, the prevalence method is basic formula.
Yes.
To calculate the prevalence of stage 3 and 4 based on a study done in 2003, published in 2003, based in Kampala again. Now again.
So what was the sample size for this study?
I used again 50% in order to verify. Now there are many factors that I considered.
And the number came to 149. It says stage of diagnosis associated factors.
Professor,
yes.
I calculated using 50% and got 384.
Yes.
And I had two top criteria at the time of approval of the study. The first one is if I realize the number of 384. The second is if I take 18 months, I stop there. And so it is the second stopping criteria that I used. I collected data for 18 months and stopped. And that is how I ended up with 149 cervical cancer patients. So I consecutively recruited all those who qualified to be in this study over a period of 18 months.
Okay, so this 149 was the study powered enough for the positive analysis to carry out later.
The power was...
When it came to analysis, these are all procedures now. Was the study powered enough?
No.
Okay.
No. I appreciate the limitation in power there, and we see for certain characteristics, the confidence intervals are really quite wide.
Okay, so you collected the data and put people enrolled over a period of 20 months to be exact. It was 20 months. I counted the months. And could these factors you're studying have changed over the 20 months period?
So my independent variables, as we looked at, I do not have reasons to believe that they could have changed over the period of time significantly to influence my result in another direction. I wouldn't think so. The factors that I looked at here.
It's okay, it's fine. So how many patients in Lacho had early stage disease over the 20 months? How many patients in Lacho Hospital had early stage disease, stage 1, stage 2?
Because in my analysis, I decided to categorize. So most of the information I have now here is categorized. But I think there were perhaps only about 15 in stage 1. And majority were at stage 3.
Okay.
Yeah.
Would this information have been helpful in you being studied differently?
If I had prior knowledge?
No. If at the decided stage you had thought about another approach, since you might run into problems of 149 far too low for the power the study for the quantitative analysis you wanted to do, you could think of another approach to this study.
Yeah, another approach.
Looking at early stage versus late stage disease.
That's exactly what I did.
Early stage.
Early and late, yes. Putting stage 1 and stage 2 as early and stage 3 and 4 as late. Now,
so 149 contains both early stage and late stage disease.
Yes, sir.
So, suppose you have done a different study. It's called a case control study. You are looking at the pathway here.
Yes.
Yeah? Patient and primary care related factors.
Professor, I think for me to get to the same, but in a better way, without being a multi-center, to look at 2 or 3 more hospitals, that could have given me power. Now, if I went on a different method, a case control, I will perhaps come out with some findings that.
Usually when you compare cases and controls, it's not a ratio of 1 to 1, you can have 1 to 2, 1 to 3, 1 to 4, 1 to 5. And it generates very interesting information. Let's move to the last study, number 5. If you go to the paper, I gave you number 5. Perceived barriers to biomedical care for cervical cancer. And I found the same challenges, using your terminology now. In the objective, you talk about exploring perceptions of healthcare professionals on challenges during screening and health seeking. And then under study 5 paper 6, you talk about challenges, proposed remedies. You don't talk about barriers. That's why I say you use this interchangeably. Now, under the objectives, interestingly, you brought out the issue of screening, which didn't get much attention in the literature review, which was rather difficult. Screening. But it appears here, and then you have that. So how many departments of obs and gyne are there in Lacho Hospital?
There is only one hospital.
This study was done in 2 health facilities?
Yes.
Okay, so that needs to come out here. Okay. Otherwise, we're training and say one hospital, how many departments does it have? How? It was not very clear there. So I've finished with this. I will now proceed. So when I finish this methodology, that's page 36, 35. 35. I missed a chapter on the results.
Yes.
Because of the study.
True. I deliberately chose from the guideline the format that allows me to present a book without a result chapter. There is a guideline from the Directorate of Research and Training that gives provision of the different formats to use. And when I realized that I could perhaps have some publications and results would be within the publication, I chose the second format, which does not require me to put result section as a separate chapter.
Okay, one, these publications you have, do they have all the results that you got from the research?
They do not have all the results that I got from the studies.
Okay.
Indeed.
So it's important then, yes?
But they answer all my objectives. The results in the publications answer all my objectives that I set out to achieve.
And those objectives were just examined in this format. They don't match the other 5 objectives.
Oh, the differences here are really styles and formats and the use of languages. But I think in principle and in concept, they are the same.
Okay, so you probably revisit this issue of this chapter, but usually for a doctoral thesis of this nature, there should be a chapter on results because you are able to include a lot more data findings, which does not go into the publication. It allows you to flourish and be able to expose more of the work that you have done. Number 2, when you put your publications in the middle of this book, these publications are not yours. They are copyrighted to these journals. You are not allowed to put them in the middle of the narrative of your thesis. You shall put them at the end as an notes. So they are not yours. You have to seek permission from the journals to incorporate them. So this is something perhaps that needs to be revisited. So it then made it quite difficult for me to internalize and understand the discussion, because the next chapter then was discussion and the individual papers. So I will straight away tackle the first paper, which is understanding cervical cancer and exploration of lay perceptions, beliefs, and knowledge. And what is an exploratory study?
As opposed to explanatory, this was exploratory.
Yeah.
In the sense that I went in to gather information, primary information at the start. As opposed to explanatory, where I have information and go to gather further information to understand it.
Okay, so exploratory studies usually will not lead to understanding. You're exploring in order then to be able to do other studies to reach bigger depths. So I found that the application, they are difficult to understand. The next comment on this paper goes to the study setting, where you say that the study was conducted in Gulu district during May and June, and you describe Gulu and other regions as rightly so, an area that went through insurgency for more than 2 decades. And people were displaced to IDP camps, and you are aware of that. You chose 2 villages, and you termed one rural, one urban. And my understanding of the context, when people were in IDP camps, were they in urban or rural areas? First question.
Thank you. During the IDP camps existed in various places. Some were deep in the villages, in very rural places. The idea was to have protection of the arm. But by the time I was going to do that collection, people were really returned to their homes. And so the camps were really no more in existence.
So what makes you so confident in the presentation and discussion of a big divide between rural and urban, when people have been in IDP camps, insurgents for more than 2 decades, in fact, you mentioned 26 years, from 1986. And then suddenly, as soon as you went to do the studies, there was a clear delineation between urban and rural. That's what I was trying to understand, the context. Of course, for example, reading from Bulaya outside there, they will not know, but I've lived in Uganda. My parents have lived in a camp. So I know what it is. So I wanted, how come now there was that sharp division between rural and urban? A few years after they left, I did camps.
The ruralness and the urbanness really do not relate to the camps, in my mind.
But to the people,
respect to
living in a particular place.
And not the behavior of
no, people live in a particular place.
It is the location, yes.
Yeah, that's
it's just the respect to the location.
So I'm saying they were in a camp for 2 decades plus. A few years later, you go to do a study of the camps. And then there is this big, even when you discuss the results, a big divide between rural and urban. You can't understand what transformed it so quickly that there is a big divide when they have been in the camps.
I have actually not drawn so much the rural urban divide in this particular discussion. Really, that much. Yeah.
Okay, you look at it and see. The next one is on data collection. And I note there were 13 focus group discussions for men and 11 for women. Is that correct?
Yes.
Yes. And the phenomenon studying is symptoms, vaginal bleeding, vaginal discharge. So in Acholi region, what's the number of menstrual periods over the experience in our lifetime?
The number of menstrual cycles a woman should experience.
Periods.
The normal menstrual cycle. So,
you see, the anchor of this study is vaginal bleeding, symptoms, and how they react to that phenomenon.
So the normal bleeding is related to the lifespan of a woman.
No, but how many?
Perhaps 49 minus 15, that would be about 34 years.
Yeah, that translates to how many days?
So 34 months, once a month.
Okay, you will sit down and calculate. So I go back to give 30 groups for men and 11 for women.
Yes.
And you are studying that phenomenon. Is that justified? 13, we have more focus group with men. And I noted most of them were young men. The large number of focus groups were young. More focus group among men than women. And we're studying a phenomenon where women experience symptoms. We're looking at the pathway to diagnosis and late stage disease and so on. Awareness and perception. And these are the things we're discussing. So I just wanted you to make me feel a little bit easy about this.
Oh, thank you.
Yes. So many men versus so many women.
In fact, there are not as too many. The difference is really one focus group.
13 and 11. 13 and 11. I've counted.
Well, that's about, because I have 4 plus 2 plus 6 up the other side. And then I have 4 plus 3, that's 7 plus 4, that's 11.
Yes, 13 versus 11. So 2 more.
I was confirmed.
But the issue here, the rationale of involving men in this study is because cervical cancer is not just a disease of women. It's really a disease that affects the family. It affects the husband, it affects the children. And we also know the balance of power and resources is tilted a little bit more onto the side of the men. And if the man does not give permission, for instance, to the wife to go for screening that long distance, perhaps that may not happen.
It's okay, leave it. It's okay. Continue. I'm using the book now. So I'm not very convinced. A phenomenon like this perhaps could have been wise to have more women groups than men, unless the research question. You see the problem with the research question. I don't know what the research question says. But towards the end of that paper on discussion, you bring out a very important aspect of discussion, but it come out in the actual focus group. And that is the main symptom for cervical cancer, apart from bleeding and vaginal discharge. That's why now when you have a lot of men in focus group, that females, it may affect your results to some extent, even affect your discussion and conclusions. We move on to the next paper. I'm just reading through. The next paper is Barriers to Biomedical Care and Use of Traditional Medicines for Treatment of Cervical Cancer. Another exploratory qualitative study in northern Uganda. And on sampling, again sampling procedure, you went to people who had lived in a particular place for 18 years. And I'm going back to that context, that people are in IDPs. And some lived in IDPs in rural town and went back to the rural areas. And they lived there for 2 years. Were those excluded? Then you need, but you've published here that only those who have lived there for 18 years. It means for rural areas, all those who have lived there for 18 years would be included in the study.
No, the period being referred to here is Guru itself.
Guru?
Yeah, Guru itself, not the particular village where the person was interviewed. That inclusion and exclusion criteria is for Guru as a whole, not the particular village.
Okay. I don't think I've understood very much. This is the same study, the focus group discussions. And the methodology was to contact the local council official, one, to mobilize the people who lived there. And those people must have lived there for 18 years in that village. Not every village had an IDP camp. That's why I was having difficulty to understand how these participants fulfill that criteria. But we can move on. The results are presented, and it would have been helpful to, again, to tease out in relation to specific aspects of areas, the male focus groups from female focus groups. Because when I did something like this, that participants in the majority of focus group discussions gave testimonials of circumstances when their conditions got worse while waiting to be helped in hospitals. My assumption then is, was it only for the female focus group discussions, which were 11, or even for the 13, and the men actually got cervical cancer, and their symptoms deteriorated after the waiting? I know. My senior, my teacher is worried that even at this late age you might get this. So the concerns in terms of presentation and going backwards, male, female focus group discussion, and certainly participants in the majority of focus groups, I think is the correct thing. What's the point of analysis of focus group? Is it the individuals?
The unit of analysis is the focus group itself.
So this should refer to focus groups, not to the... Yes. Okay? Yeah, it should be the focus groups. Okay? Good, thank you. We move on. So I did that study, I go to the next study. And the next study is health expectations, awareness of cervical cancer risk factors. And as I mentioned earlier, this study on health expectations, if you go to page 3, there were the sample sizes and sampling procedure. You go on to data collection procedures. And I was wondering why data from study 1 did not inform this study. This study was done much later.
Yes.
Yes. Instead, what you are quoting for data collection, you say we collected data using structured pre-tested questionnaires which contain themes adapted from findings and tools from East Africa, South Africa, and so on. Yes. And completely do not refer to the past study. Right.
So the factors that we assessed here were completely different, I would say.
Okay.
Yes.
Under the results, awareness about cervical cancer, I was curious to know those percentages. How many of these respondents knew what the cervix is? You asked them what's the cervix.
The women themselves have a double name for the cervix.
Yeah, where are those results?
They do. No, I didn't really take that as part of wasn't really much of the objective, so I didn't include it in here.
Then how do you go to spread awareness about cervical cancer and you discuss the cervix? And you give proportions, 70% reported this, 80% reported this, but you don't go to the anatomy section. What are, how many know what the cervix is and where it's found? Did you ask them where the cervix is found?
No, I did not take them along the line of anatomy. I was rather in the line of sociology and medicine. Medicine really being social science in itself. And that's why I tried to rest my study.
Okay.
Yes.
On page 24 under health expectations, you are just analyzing. These are 2x2 tables, but you went on to do p-values. I was wondering about the value of these p-values for the various age groups. The majority of people were Catholic, 79% and 76%. They were the majority when you look at religion, that table.
Yes.
Yeah. So after that, you don't refer to this finding at all.
Of this background characteristics in relationship to the awareness that I
yes.
When I went into practice paper has 12 in the published form it has got 12 table supplement. Now I went through and most of these background factors are not consistently associated with the factors that I look for the recognition of the symptoms. So really, I didn't discuss them that much because of that.
And the study was not thorough enough?
No, this study was quite enough.
Is it? Okay.
This was quite enough.
On page 26, table 2, cervical cancer is preventable through vaccination of young girls. And a quarter of the men knew, I think, and 1/3 of the women. You're using a biomedical model here. You ask some questions like whether this is sexually transmitted. How do you translate sexually transmitted into a child?
That is one thing that I put in the limitation, that there are concepts that may not necessarily be directly translatable.
Why don't you just ask them that if you have sex, you get the disease? That's a very easy concept, isn't it? A very easy concept. You went for the biomedical concept. Right now I was saying it's a sociologist. He has come back to this side. So I found it strange that you would use a complicated terminology and concept to ask people certain questions. Instead of saying, well, if you have sex, you think you get this, you use instead sexually transmitted, which was quite difficult to conceptualize, isn't it?
No, but this is the presentation. The way it was asked was different, and the questionnaire. This is now being presented for the wider...
No, you should just present it the way it is. You see now, social science studies, it is not epidemiological study. It is an epidemiological study.
This is a lot more epidemiological. This is the qualitative survey.
Okay. Yes. And I found the same problem with the question subsequently. There are tables, I will not go into that now. The last study, I think, study 3. In this book, every line, every sentence has a number. What?
Oh.
The whole paper, everything is numbered.
Oh, this.
And I thought this is a new format.
No, not at all. These numbers are because I put in here papers that were already submitted. So the numbers are from the journals?
No, you come closer. Come 51, 52,
Yes.
75. These
Yes.
numbers are for.
These are numbers when I was submitting to the journals.
Yes, but you don't present this type of paper in your thesis. This was given to the examiners.
Right.
Right. Okay. On page 3, the conclusion, he says you gathered patients with symptomatic cervical cancer and misattribute their gynecological symptoms and experience longer pressure and help-seeking intervals.
Yes.
You see, you're interpreting now like a sociologist, not like an epidemiologist.
This was qualitative.
And that's the same paper we're talking about.
No.
Let's move on to the next one. Okay. Methods, design, interview guide. And so these papers are quite hard, especially this one with the numbers. I will go to BMJ Open, Social Demographic and Healthcare Factors Associated with Stage and Diagnosis. This is the study that again is in the BMJ Open Access, isn't it?
Yes.
And on page 3, as soon as you finish the keywords, you present the strength and limitations of the study. Of the publication. Those are the difficulties of this presentation.
Yes.
Good. And the last bullet says this was the hospital-based study. You're not using the cross-section study. You are saying this is a hospital-based study. You don't describe what kind of study.
It's a hospital-based cross-sectional study.
Yes. And the methodology on page 6, the theoretical framework, you refer to figure 1 when you talk about theoretical framework. It's a theoretical framework, the same as model pathway, figure 1.
It is the same one that I'm using.
What's the difference between the model pathway and the theoretical framework? So they're the same thing.
The model pathway to treatment is an example of a theoretical framework, and it is the one that I use.
So then in the text here, you should refer to the figure correctly. The figure says model pathway, not theoretical framework. Okay, good. Yeah. So that somebody reading through this gets the right picture of what you're talking about. When you see them like this, it's really confusing. Yes, so I have no other comments on that paper I had, but I will leave them there. It goes on, even on page 17, you refer to that figure theoretical framework when actually the title clearly says model pathway. And so one should be very careful. You don't tell a father from complaining that you're not quoting them well. I think the last paper is Mind the Gaps, a quantitative study of perceptions. And I looked at the people who interviewed, the number of nurses, midwives, and so on. And you quote under sampling method and respondents that these were people who had the capacity to manage cervical cancer. So but you did describe what this capacity is. You just said that these people have capacity to manage cervical cancer, but you didn't say what capacity.
Oh, I didn't read.
When you look at the list, it goes from an enrolled nurse, enrolled midwife, to a specialist.
They work as a team. I have given their different categories and cadres.
On table 2. On table 2. But you need amply amplify what this capacity is.
So what each one of them does in the process of managing,
Yes.
That would be a big thing.
That's why you need more opportunity to flourish in the thesis. Publication box into a corner. Table 3. Table 3. You list the questions there and analyze for each person. And I found it difficult to internalize this table. There were how many health workers?
So these were 15 health workers.
Yeah, 15 health workers. Then you analyze them in the table. Some, there was only one respondent, others 2, others 3, and so on. And so, why did you choose to present the results like this?
So this one is a presentation that is trying to bring out the science of the issue with respect to the number of respondents who emphasize a particular issue.
For example, lack of formalin.
Yes.
Only one person mentioned it, or only one person was asked?
It was only one person who mentioned it.
But when you look at the capacity to manage cervical cancer, how many of these enrolled nurses and these other people included would have been able to talk about lack of formalin?
Well, I guess it depends on where the nurse herself is located. Even the nurse is in theater, then we know a lot more about the use of formalin in this. If they are in the screening center, like where I interviewed some, they will do that. Those who are in the gynecology ward where EUA is also done, they also interact with the gynecologists who do that. So I believe that they would know about that.
Exactly. That's why I think you'll agree with me that when you have a table of results, you are able better to present this kind of results than having one respondent talking about formalin. Then you don't differentiate between among the 15, who do you expect to know about lack of formalin in their role as managers of cervical cancer? Among the 15, these are key informants, that's what you say, isn't it? Yes. Who among the 15 would have the capacity to know about the importance of formalin? All the 15, or 6, or 7? Only one person mentioned it.
Yeah, so of all the 15, it was only one person who talked about it as a problem.
Yeah, so the way it's presented here, it's not possible for you to disaggregate and present a picture which will inform people that all these 15 should have known about lack of formalin. Okay, good. So I think I will stop there as far as these papers are concerned. As I said, there is no chapter on results, and I found it quite hard then even to go on and tackle the chapter on discussions, because the discussion then is talking about individual papers, results from individual papers. And whereas usually if there are chapter on results, you're able to deal with that. The section of discussion is 6.11 and onwards. And the discussion then goes to address papers instead of addressing particular themes and areas. And that is a bit of a problem. 6.11 in your discussion, you are there 6.11. And the next chapter 6.2, and the next one, you say that most community members were aware of cervical cancer and its risk factors and treatment. So how did you reach this conclusion?
So the evidence released from study 1 and study 2, as I indicated in bracket right there. In study 1, they reported by themselves. In study 2, I got a quantitative approach to it and have it in terms of percentage.
But in study 1 and 2, the analysis unit is a focus group, not members of the community.
From study 1, there are 2 papers. And then study 2 is the subject.
Yeah, this one is referring to the community and the focus group discussions and so on. And the conclusion is most members of the community were aware of cervical cancer and its risk factors. And I'm saying now, but we're studying those focus group discussions and key informants. So how did you now know about members of the community?
That is my study 2 council. In the bracket, I put as evidence that study 1 and study 2.
Study 2 was a bigger, a broader survey in the two counties.
So then that particular paragraph is relevant for study 2. most members of the community. He gave me the impression he had done a survey in the community. When you say most members of the community.
Right.
Yeah.
But again, there was also only one key informant who didn't know about cervical cancer. All the others actually talked about it.
But key informants are purposely selected, isn't it? Purposely selected. So you selected all those who had gone through a sensitization workshop. Okay, let's move on. 6.14, symptom appraisal on health seeking for symptomatic cervical cancer. What I noted you have not discussed here is bleeding. Thus I asked you how many menstrual periods a woman experiences during her reproductive life, 50 to 49. So you discuss a lot of things about symptoms appraisal and health seeking. For a woman between 15 and 49, a key thing in her life is menstruation, bleeding, isn't it? In the discussion, it's not there. Because it's important then for symptom appraisal, isn't it?
I say that many of the women attributed their symptoms to normal body changes. I don't know in particular paragraph. But actually, many of them said, oh no, I thought it was the menstruation starting again. That's for the older women. I guess I brought that quite somewhere in.
Didn't come out well. Didn't come out well. So I noted that there was confusion. When you're discussing women, you did not tease them out. And yet when you look at the participants, they were age given 6, 8, 7, and so on. So I think that's important. I will stop there with discussion. We're running short of time. Chapter 7 is about conclusions, and there are 8 of them, and they should be in bullet form. The second last bullet talks about reported several perceived barriers. As I say, you have used barriers and the others interchangeably. I found most of these conclusions would have been better if they had been numbered. Number 2, if you took into consideration the local studies and the national strategic plan. The conclusions did not remain in good. They were very general. Why? One of the limitations you said is generalizability of these studies. So why did you focus on northern region? No.
I think,
for example,
yes.
What are the work plans of Gudu district as far as cervical cancer screening is concerned? And Gudu, when cervical screening was rolled out, the ministry said they first roll out in all the referral hospitals and then the general hospitals. And each district must present some kind of work plan. I expected to see the conclusions and recommendations a tie-up with northern Uganda.
So I had the opportunity of looking at the data at the regional referral hospital, the screening data, but I didn't see how I would bring it into my thesis here.
No. In terms of conclusion and recommendations, I think this study should have brought it Gulu on board, the regional referral hospital. And if they are not doing it, then there must be policy or guidance to them. Similar Lacho and the district that refer to Gulu. Thank you very much. I think I'll finish.
Thank you.
So, take it.
No, it's okay.